Yeah. Maybe we talk a little bit about the AI, as you are also expert on that. So how would it go in this kind of setting that we have a larger database of people who have, for example, got certain kind of pain treatment, medication, maybe physio. So you would understand something from the data, and would you then, with the AI, match some of the demographics or some of the questionnaires to this patient, or how would it work? Just kind of trying to understand without not knowing anything about this kind of AI research. How would it be done that this could work?
That is exactly one approach, to have, let's say, matching patients in your database that have, for example, same age, same sex, same operation, maybe the same social cultural background. And then you look at your database and look how many of similar patients are there according to a distance function that looks somehow, how far away is this other person that's in the database to the person sitting in front of the clinician. And then you could look at their treatments and their outcomes. For this, obviously, you need large data sets with lots of patients that have lots of different variables. In the ideal case, the whole health data of the whole world. But obviously you won't get that. But this is also, let's say, a difficulty. If you analyze weather data with artificial intelligence, the sensors you have, they are pretty straightforward. Every hour they give you the temperature and maybe air pressure. It's at different places. And then you have an immensely huge database where you can easily apply artificial intelligence models and they will find something. That is not so easy for patients. First, because there's not so many. Your databases will be much smaller. And the second thing is, especially with pain, that pain is so subjective that you cannot fill holes. So for example, in weather data, if you have, at 1 o'clock it was 10 degrees Celsius, and at 3 o'clock it was 10 degrees Celsius, then you can be relatively sure that it's 2 o'clock. The sensor would also have said 10 degrees Celsius, even if it failed at that moment. So you can easily fill the hole. But for two patients that have the same demographics and the same treatment and the same procedure, it's not clear that if one says 4 and one says 6 for their pain level, that the third person would say 5. It's totally unclear. The third person could also say 0 or 10. You don't know at all. And this smaller data set with more holes makes it a more difficult analysis for AI. So this, what we first laid out, this pattern matching, that is one point you can go, but obviously in the ideal case, you want to have neural networks that dig very deep into the data and find solutions that you as a person would not find. But this is not so easy because the data is sparse, but nevertheless, it's worth the effort to go there and to find the fitting algorithms and to have intelligent people think about it and improve the lives of everyone, not just for pain.
Yeah, that's interesting. And I'm thinking now that basically more the AI have data, it can find like surprising connections. And as we discussed, for example, that the attitude might affect how you feel pain, and then like what kind of data you can have about attitude. Maybe books you read affect your attitude and give something. And then I think in Facebook people list like what books they have read, or your Audible account, that it could be really like feel like that it's something totally unrelated. But if we can give, of course, then there's always the privacy thing, which is problem. But basically for AI, just more we can give, even if it feels unrelated, there might be things that link. Or what's your take?
Yeah, I'm from Germany. I always think our data security officers are I'm not saying worst, I'm saying hardest in the whole wide world. I'm not sure if that's true, but in Germany, it's very difficult to, for example, combine data from different sources. You have to de-anonymize or de-pseudonymize patients to do this, and this is always relatively difficult. But I'm again saying something good about the European Union. There are laws out there now that try to improve this setting. We will have a broad consent soon that allows or gives researchers more access to anonymized data in the future. And it will also make it easier to do data combinations of different sources, which in principle is the end. What you laid out is exactly true. It could be that patients with anxiety or depression, which are more prone to pain, have a totally different lifestyle or listening attitude on Spotify or whatever. And combining this would give us a lot of insights. And it might even be worth for Spotify to change their recommendation process to maybe something that copes with anxiety or depression, or something that is very simplistic, makes people happier. I'm just guessing now. But that's exactly the point. And I feel that currently the regulations in Germany and also in the EU are improving in that manner. So we had hard years where data security officers in principle forbid everything. This is changing right now, because also in politics it is now understood that we take away some privacy. I mean, patients are not de-anonymized yet. The researcher never knows who that patient is. That has to be said in advance. But that giving researchers more access to data will improve the lives of everyone. And I mean, that's the ultimate goal. And giving in some data privacy for that higher goal, I think is worth. I mean, I'm a researcher. Obviously, I'm biased in that manner, but I think it's worth it. And not just for us, it's for all researchers, and especially in the health sector. It is very important to look at long-term outcomes, not just short-term outcomes. It is important who develops cancer, who dies at some point, who develops chronic pain. That is very important. It could be half a year or 1 year later, or maybe in 5 years. And there is not a lot of good data sources out there that have this long-term observation period. There are some, but very few. And I think we're going in the right direction politically in that manner right now.
Yeah, sounds good. And maybe talking about your future studies, what kind of studies you are planning, your group is planning. Is there any AI studies coming? Could you tell a little bit about your future plans?
We will have AI in our future projects. It is a hot topic. It is well funded right now. And we now have databases that are large enough to start working on AI and pain. So this will for sure be a topic for us. In the activity part of research, we are currently giving birth activity trackers. So not cesarean section, but natural birth. They come to our hospital, give birth, and then get the activity tracker, and we collect data on the well-being of the mother and the child. For example, if they are able to breastfeed and so on. And I'm really looking forward to that, because there's no data whatsoever out there on activity of new mothers. This is really interesting, and we will see which kinds of treatments improve activity, improve the well-being of the child. If mothers breastfeed more, that move less or more, we simply don't know that yet. So this is really interesting. Second topic is also palliative care patients. Palliative care are those patients that are at the end of their lives, where treatment won't heal them anymore, but is rather an opportunity to make the lives of the patients better shortly before they die. And also here, the question is, which treatments are appropriate, which treatments are too much, which treatments maybe are needed to improve the quality of life of patients and activity. Being able to get up out of bed, being able to talk to people is obviously very important there. So this is a topic we're working on, and a very specific outlying research is the research of activity and horses. We are actually in Bern applying activity trackers to horses, because some horses develop so-called head shaking. Yeah, they have an unnormally strong up and down movement of their necks, sometimes so strong that they even hit their riders with their heads and hurt the riders. And there is a drug that could help with that. It's a drug that is used in human patients, and in Bern they want to try giving this drug through the nose to horses and see if this reduces the head shaking. And obviously, head shaking is something that could be measured very well with measurement devices that measure acceleration in some axis in space. Yeah, so this is very interesting too. But in general, our group is going besides activity and maybe even sleep to looking at other outcomes of surgeries. So we talked about pain a lot in this podcast. But we also want to look at other outcomes. For example, if patients develop infections after surgery, if they have a bleeding in their wound and so on, and how those are connected to pain, of course, but also as a long-term predictor of problems that come up later in patients' lives. And as we talked about it earlier, this needs a lot of data. This needs the connection of different data sources. And it's also a hot topic. There is research on this, on single data sources, but the linkage issue is coming up more and more, and we want to improve this research too. So post-surgical outcomes will be our hot topic, and activity is one part of it, but not everything.
Yeah, sounds really, really interesting studies. And maybe just to give an idea, we have a small accelerometer sensor, and I think it fits well for the AI studies, because with the one charge or the initial charge, it can measure 22 weeks of raw data. So basically,
that is a lot.
Yeah, and when you're doing with the AI, more data you can give, more you have, and of course, like if it's about pain, if it's about giving birth and then recovery, there's certain slope, and if you actually measure more than the normal 1 or 2 weeks, you actually get the slope, and you see that how does it progress, how is it somewhere going like wrong. For example, if you have somebody have pain and they are recovering, but then the slope kind of makes some kind of something else, you could compare to reference data and you could know that something is going wrong. But yeah, I think it's very, very interesting studies coming. And are you looking for any collaborations? Do you have the team that you want to have this kind of things? We have many kind of listeners. Are you looking for any collaborations?
We are always looking for collaborations, and especially with patients. So it's very easy to diminish your patient numbers. For example, if you say that you will that you will only look at one surgery, then the number of patients in one hospital gets small very soon. And as we talked about, you need large data sets, long-term observation, but also observation from a lot of patients. Then it is very helpful if there's other hospitals out there collecting data. For us, interesting is also healthy comparison group. It is not so easy to find a healthy comparison data. So if someone has it, we are open to that. And if someone wants to contact us, we are happy to have them. We're always looking for collaborations, of course. And we did not talk about the technical details of activity trackers today. I guess you did that in other podcasts. There is a certain set of devices out there. There is a lot of devices out there, and the specifications sometimes fit very well to your project. Sometimes they don't. All have advantages and disadvantages, and this is a topic of its own we did not talk about today, but it's interesting to hear from your device, and we are always looking for collaboration. So feel free to contact us. Yes.
And as you come from the AI and computer science perspective, how do you see the specifications of the device? I think it comes down to kind of data size, and then the frequency, sampling frequency, resolution, that how much you want as high, but you don't want crazy size of data. So what's your take on it?
When we got into this topic, I tried out a lot of devices. And I started with devices like Apple Watch and Fitbit and some stuff like that, because I thought that it would be easier to implement, to get the devices, to get them running. People know these things. It's not something that is very scientific and looks totally different than everything they have normally on their arms or wrists. But then I realized very quickly that this doesn't work, because all those companies don't give out their algorithms. And as a researcher, you need the raw data, and you need to know exactly how, for example, the number of steps is calculated. And you don't get that in an Apple Watch, and you don't know if they change their algorithm from this day to the next day, and so if your data is even comparable. There are a lot of studies out there that use such consumer devices, and if they all use the same devices, all patients use the same devices, this might work as a group in itself, but I think it's not scientific enough. So in the end, this is my main topic, but obviously, longer times is important. If patients need to recharge the device every day, that's bad, which is by the way, also true for example, for an Apple Watch or a Samsung Watch or whatever. So long battery life is very important. Obviously, long data collection times is very important. I think for our purpose, if it's measured like 100 times per second or 10 times per second, that's not in the end the most important topic. But what is important is that patients can use it easily, that it does not impede them in any way. So if they feel that the device is barring them from doing anything, for example, taking a shower, so that's obviously bad. So if they don't have to take it off, if it's small, that's the thing. What I also think is an interesting topic is the Hawthorne effect. The Hawthorne effect is if you look at something, it changes. That's very, very simply said. So if you use a device that has a display and patients look at the display, that might bring them to move more. Yeah. If everyone gets the same device, then you have an average effect on everyone, then it's fine and you can compare it. But if you want to compare different studies and you have one device that has a display and the other one does not have a display and does not report anything, then you can't compare those two, in my opinion.
Yeah.
And that's all issues. You see, there's a lot of specifications that you have to look at if you want to do a research study on that. But yeah. As it's your company and your area of expertise, I'm pretty much sure you have a lot more to say about that than I do. Yeah.
No, but it's always interesting to hear the other perspective. But yeah, basically it's the same thing. Like usually the consumer activity trackers don't work really well, and you just want good compliance and raw data, not super high frequency, but just enough basically. But it has been very interesting discussions, Markus. It was pleasure to have you in the podcast. So thanks a lot for taking the time for this recording.
Yeah, I thought it was a lot of fun too. So thank you for having me, Olli.
Yeah, thanks.